My name is Precious Idogan, and I am a PGY2 at Florida State University Internal Medicine Program at Sarasota Memorial Hospital. Today, I will be discussing complete blood count parameters, outperform putative inflammatory markers in predicting COVID-19 mortality. In this study, we essentially try to determine if normal CBC parameters, which are measured very often during a typical hospital stay, would help to contribute independent information to a model predicting mortality in hospitalized patients with laboratory-confirmed COVID-19 infection. Such a model may then complement or improve presentation risk stratification that's normally informed by putative inflammatory markers. For our methods, we used a retrospective design. Under IRB exemption, discharge medical electronic health records underwent extraction of administrative and clinical data, demographics, anthropometrics, vital signs, laboratory tests, and comorbidity categories were included. Univariate logistic regression was used to identify CBC parameters and ratios associated with hospital mortality. A two-way ANOVA was employed to compare survival versus non-survival pathways. For our results, among patients consecutively discharged between March 14, 2020 through May 31, 2020, 208 or 10% died. Survivor versus non-survivor patient and clinical characteristics are summarized in Table 1. CBC parameters that were identified as independently associated with hospital mortality included white blood cell count, lymphocytes, bands, segmented neutrophils, monocytes, and RDWCB. Ratios of CBC parameters associated with mortality included AMC-ALC and APC-ALC ratios. Results of bootstrap forest modeling of CBC parameters without inflammatory markers demonstrated a R-square of 0.65. Results of bootstrap forest modeling of CBC parameters with inclusion of inflammatory markers demonstrated a R-square of 0.70. Inflammatory markers alone exhibited the lowest R-square of 0.52. This is illustrated in Figure 1C. Figure 2 illustrates temporal kinetics of modeled CBC parameters across hospitalization. Intergroup differences at baseline were sustained, except for RDWCB after 5 days. Table 1 demonstrates different patient characteristics and variables, including age, sex, race, BMI, and comorbidities, including hypertension, diabetes, iron deficiency anemia, and CHF. Figure 1a demonstrates different CBC parameters that, when trended against mortality, demonstrated a positive correlation with R-square of 0.65. Figure 1b demonstrates different putative inflammatory markers which, when trended against mortality, demonstrated a positive correlation with R-square of 0.52. Figure 1c demonstrates combined CBC parameters and putative inflammatory markers which, when trended against mortality, demonstrated a positive correlation with R-square of 0.70. This shows that inflammatory markers alone demonstrate the least correlation to mortality as compared to CBC parameters or CBC parameters in combination with inflammatory markers. Figure 2 demonstrates CBC kinetics. Blue represents no mortality, while red represents mortality. In general, individuals with higher baseline white blood cell counts, higher bands, or a higher APC-ALC and AMC-ALC ratio demonstrated increased mortality. In conclusion, machine learning approaches identified several CBC parameters measured at presentation that, when modeled with non-COVID-19 inflammatory markers such as CRP, LDH, and ferritin, enhanced early prediction of hospital mortality. CBC parameters are usually more often measured compared to other inflammatory markers that show COVID-19 severity and thus serve as an easily obtainable source of information to determine which patients may require a higher level of care before clinical symptoms follow. This includes progression to critical illness and hospital mortality.